All right, everyone, we are going to go over chapter 42, which is lower GI problems. I do want you to note in both this PowerPoint and in the, I gotta sneeze. Oh, excuse me. That in chapter 42 and in chapter 43 with the liver, biliary tract, and pancreas disorders, that there are lots of notes in the notes section of these chapters, just because it is a lot of information and I don't want to lecture for 4 hours over all of this. You guys would like be numb to what I was saying anyways, but I've kept it kind of short and sweet, main points in here, just to help you reiterate as you're studying. Several of these points I'm obviously going to mention while I'm lecturing, but just make sure that you are looking at that notes section because it is material that can be included on the test. So with that being said, we're going to go ahead and start. So the first 3 slides are slides that you're all pretty well familiar with, I'm sure, conditions that you've heard about. They're very common. So we'll briefly go through them. Diarrhea is diagnosed as the passage of at least 3 loose or liquid stools per day. You do have to get kind of up close and personal with patients asking about their bowel movements, especially if they come in with a chief complaint of diarrhea, and that's what they're being evaluated for. Some people do not have diarrhea by definition, even though they're claiming to. So it is at least 3 loose or liquid stools per day. The primary cause of diarrhea is infectious organisms, whether that's viruses or bacteria. If a patient comes in and we find out that they have diarrhea of infectious organisms as the cause, then we do not want to give antidiarrheal medications. If you do that, then we are preventing the bacteria or virus or whatever infectious agent from getting out of the body. So we only give antidiarrhea medications for reasons like just like stress diarrhea is like kind of the most common. If they have diarrhea as a result of like a chronic disorder that they have, then we can give antidiarrheals. But if they have like a viral GI bug or a bacterial infection from like traveler's diarrhea, especially if they have something like C. diff, we don't want to give antidiarrheals for that. We want to treat it and flush that infectious organism out of the system. Stool cultures are not very commonly done, but if they are very ill and measures that we're doing to try to prevent the diarrhea is not working, then we may want to see if they have something like C. diff. And if you've ever done a C. diff culture, those patients have liquid stools. So if you're getting a C. diff culture on a patient who has solid stools, you know that's going to come back negative. C. diff causes very liquidy, repetitive stools. And we just confirm that with a stool culture assessment. Again, just to reiterate, the treatment depends on the cause. It's usually self-limiting, so you just let it run its course. That's the case for most viral GI bugs. They are at high risk, however, with diarrhea of becoming dehydrated, and then that can lead to fluid and electrolyte imbalances. So we want to monitor that, make sure that if they can't hold down PO fluids, that we're replacing it IV, that we're taking labs, CMPs to assess for their electrolyte function, and make sure that that's all within normal limits. And then again, only give antidiarrheal medications for those who do not have an infectious disease going on with it. And the treatment for C. diff of note is Flagyl and vancomycin. So it does take those 2 special medications in order to treat it. It's actually usually caused by other antibiotics, which throws them into C. diff. C. diff is a type of organism that will, what am I trying to say, kind of overcome the system with other antibiotics. So antibiotics work by destroying, they're not specific, so they destroy all of the bacteria in our system, and that can destroy our normal protective bacteria or our normal flora in our GI system. When that happens, C. diff can kind of invade and take over, and so that's why it needs those strong, potent vancomycin, Flagyl antibiotics to take care of it. Then we have incontinence. This is the involuntary passage of stool. You've probably heard of like urinary incontinence before. That's common in like older females and pregnant females who, like they sneeze and a little pee comes out, that's some like stress incontinence. Older females can have issues with incontinence just from weakened pelvic floor muscles. This is very similar, only it's stool or fecal incontinence. So normal structures that maintain continence are damaged or disrupted. Problems can occur from motor or sensory function. So this can be an issue for like our spinal cord injury patients, traumatic brain injury patients, anybody that has like a neuromuscular disorder like multiple sclerosis, Parkinson's disease, myasthenia gravis can all cause different various levels of fecal incontinence depending on how severe the disease process is for that patient. And there's other causes listed on table 42.4 that you can look at. And then the treatment for incontinence is always going to depend on the underlying cause. So if it's if it's because of an underlying chronic disease that they have, then taking care of that underlying chronic disease is going to be the priority for them. But of course, dietary fiber supplements is always going to be useful for anybody who has issues with stool, bulk forming laxatives. If they have any kind of triggers that they notice, like coffee, fruit, green vegetables, or spicy foods can all cause that involuntary passage of stool. Kegel exercises is not only useful for strengthening the pelvic floor muscle for urinary incontinence, but it's also useful for fecal incontinence. If these non-invasive kind of treatments don't work, like the pharmaceutical agents aren't working, the lifestyle changes aren't working, then we can do different surgical procedures, totally depending on the cause and what the doctor wants to do. There is something we can do called mild electrical stimulation to the sacral nerves to help stimulate their proper function again, and that would be something especially useful with somebody who has like multiple sclerosis. Other surgical procedures they can do are targeted towards the anal muscle. So they can go towards the anal muscle sphincter and do different procedures that like allow it to work better. That's all, like you don't need to know the details about that, just that there is surgical options for these people if other treatments fail. Constipation is the difficult or infrequent passing of stools. When they do pass stools, they're hard, dry, difficult to pass, or when they do have a bowel movement, it's small and they have a feeling of incomplete evacuation, like they still need to go, but they can't. Common causes are insufficient dietary fiber or fluids. So it's very important to reiterate to patients who have frequent issues with constipation that they need to intake adequate fiber and stay hydrated. Decreasing physical activity can definitely cause constipation. So encouraging ambulation and exercise. People who frequently ignore the defecation urge, those folks that can't use the bathroom in public or can't, go during the workday or whatever, they can develop an affinity for constipation because they're not going when they feel like they need to. Opioids can certainly cause constipation as a side effect. So when you take opioids, you're usually frequently prescribed a sort of laxative or stool softener with it as well. Stress can certainly cause it. Stress can cause diarrhea or constipation, just depends on how your body manages stress and other mental health issues like anxiety or depression. And then other disorders that can slow GI transit, just like we talked about with fecal incontinence, Parkinson's and multiple sclerosis can cause constipation. Also, diabetes can cause constipation because of the neuropathy, the autonomic neuropathy that can come along with diabetes. Other causes, again, are listed on table 42.5. And then how are we going to treat it? Well, we're going to treat the underlying cause depending on what the particular reason is for that patient, but general recommendations are always going to be to increase fluids and fiber intake, increase exercise. For acute constipation, they can use laxatives and enemas. If patients were to use those on a chronic basis, it can actually cause adverse effects. So you do not want to recommend using laxatives or enemas like daily or very frequently at all. Those should just be for acute bouts of constipation, and then that they need to respond to the urge to defecate. So I love this little picture. It's a figure 42.1 in the book. It kind of breaks down causes of different GI issues, what the most concerning life-threatening effect of those things are, and then what they can lead to, whether that's septic shock or hypovolemic shock. Issues in the abdomen can very quickly turn south. So it's very important to understand what these conditions are, which between the upper GI and the lower GI chapters, we cover these. So you'll know kind of what all of these are by the time we finish this PowerPoint. And then I would really highly recommend you come back to this chart, this little picture here, and see, how well this all makes sense to you, how you can critically think through this. And if you were a nurse taking care of somebody with one of these disorders, what you should anticipate, things like septic shock and hypovolemic shock, which can lead to things like toxic megacolon, dead bowel, and death if we don't stay on top of it. So come back to this to review as you're studying. We're going to start by going through some acute conditions. This PowerPoint's kind of broken down into acute conditions that can occur in the lower abdomen, in the lower GI system, and then chronic conditions that can occur. Acute conditions we're going to look at are things like appendicitis, peritonitis, gastroenteritis, intestinal obstructions, and then abdominal trauma. So appendicitis, this one's pretty straightforward. It is inflammation of the appendix, usually caused by obstruction of that tiny little appendage by fecales or a piece of stool. So it can be a foreign body, a tumor of, oh my goodness. Okay, sorry about that. So different causes of obstruction of the appendix can be foreign bodies, a tumor of the cecum, which is the part of the large intestine or colon that's right next to the appendix, or intramural thickening. So some kind of increased growth of tissue. It is a process of inflammation, so that makes sense. Some kind of inflammatory or infectious process has occurred that caused intramural thickening of the layers of the appendix, which would cause it to obstruct. All of these things can result in distension or enlargement of the organ, venous engorgement, or like the blood supply gets very engorged. The blood supply would then be obstructed to and from. Accumulation of mucus and bacteria will collect in that area, and then all of that can lead to complications like gangrene, perforation of the organ, and peritonitis, which we're going to talk about. Peritonitis is the inflammation of the peritoneal cavity, which is very bad, and we'll talk about that in more detail in just a second. Here's a visual of what the appendix is. So we're taking this little right lower quadrant area and blowing it up here. This is where the small intestine or the ileum will go into the large intestine, and that portion is called the cecum. And right at the end of that is the appendix. There is no real use for the appendix that we scientifically know of yet. People can definitely live without their appendix. It gets taken out very frequently, especially in situations where somebody's developed appendicitis. So what are the clinical manifestations? Well, nausea and vomiting most certainly is involved. The pain is going to be very kind of textbook specific in these patients. So they usually have a persistent, continuous pain that begins around the umbilicus, and then it migrates towards the right lower quadrant where it's located, where the appendix is actually located. So it usually goes from the periumbilical area down to the right lower quadrant, and that right lower quadrant pain is actually called McBurney's point, right at the point between and it's showing you here in this diagram, this is where your pelvic iliac crests are, and it's in that corner kind of tucked into that area. That's McBurney's point. If you palpate on McBurney's point in somebody who has appendicitis, they're going to come out of the bed at you. It's very painful. So it's part of why you palpate patients on assessment. They'll be guarding. They don't want you to touch them. That rebound tenderness at McBurney's point, that's what I was just talking about. It doesn't necessarily hurt when you push down, but then when you release, that's when the pain starts. And that's because of the inflammation going on in that area. The actual pressure itself doesn't necessarily hurt, but that release certainly does. They often have a low-grade fever with this. Again, it is an infectious process, so that's where that comes from. And they may feel the need to have a BM. That is going to be a theme that's a little bit recurrent in both these acute and chronic conditions. When somebody has some kind of inflammatory process kind of taking up space and causing not proper function of the GI system, patients feel like they need to have a BM, although they almost certainly they almost always don't actually need to have a BM. It's just that pressure from the inflammatory process sitting up on their colon and their rectum, making them feel like they have to have a BM, although there's probably not any stool in the vault. It's just a characteristic of what these patients experience. And I'll tell you, when I've had patients come in with GI bleeds that are medical or GI bleeds that are traumatic, like if a patient was in a car wreck or shot in the abdomen or whatever trauma occurred to their abdomen, when bleeding builds up in the peritoneal space, that extra space that it occupies puts pressure on the large intestine and makes you feel like you have to have a BM. When patients act on that and they bear down and they have a BM, it's almost never blood, or it's almost never stool. It's almost always blood, and then they crash. So my spidey senses as a nurse are going crazy when I hear that a patient has to have a BM and they have some kind of abdominal like abnormality going on. I'm usually like, I need the doctor in here right now. They're about to crash. So when patients say that and they're acutely being seen for something, take that seriously and don't let them go to the bathroom. Tell them to hold it until you get the doctor in there and you have a plan in place for them. And then also with patients who have appendicitis, we do not give them laxatives. That is absolutely contraindicated. We do not want to force a bowel movement. That pressure of a laxative can actually cause the appendix to rupture. So absolutely no laxatives. So what are we going to do? Well, first we diagnose it by doing an H&P. Again, they're going to follow these clinical manifestations almost always to a T. I've seen every now and then somebody not come in with the right lower quadrant pain, but that's almost always what they present with. They also sometimes have like lower back pain, and actually I've seen urinary symptoms. Oh, it says it on here too. Sorry. I've seen people come in, especially males, because UTIs are not common in males and they're having UTI-like symptoms, can cause you to think, oh, I think this is actually appendicitis, and vice versa. Somebody can have right lower quadrant pain and low back pain, and they actually have a UTI. So you can quickly eliminate and figure out which one's which by getting a UA. And if they have a urinary tract infection, then they're going to have white blood cells and different things in their urine to let you know. Otherwise, it's going to be negative, and that leads you to think it's appendicitis. Their white blood cell count will be elevated. You can do either a CT or an ultrasound. The gold standard is usually a CT. You run them through with contrast or without, and can see that the appendix is inflamed and enlarged, and that they're having appendicitis. The treatment is to just take it out. You don't want to wait around and see if that's, because you don't need it, right? You don't want to wait around and see if that's going to rupture, because that causes even more issues. We're just going to have the appendix removed. And you can see here that we do pretty often a laparoscopic approach, which is much more minimally invasive. There's just a couple punctures that they'll have to that right lower quadrant area, and they'll use surgical tools to take the appendix out. It's a pretty low risk procedure, although any abdominal procedure can have its complications. This one's pretty low risk and resolves the entire issue. Pre-operatively, before an appendectomy, the patient needs to be NPO as long as possible. A lot of times they come in and this has to be an emergent procedure, and they might have just eaten. You can't help that. You got to operate on them if you have to, but being NPO from the time they hit the door of the ER is always priority. In early acute appendicitis, that means that the patient has come in to be seen and evaluated for this pain within 6 to 8 hours of onset. Get them to surgery. That's great. That's like the ultimate priority time to get them taken care of. We'll definitely, from the ER perspective, start IV fluids and IV antibiotics. If this person goes into their primary care physician, they're going to send them over to the ER to get evaluated to get the appendix removed. Again, we almost always want to do a laparoscopic approach, but sometimes we'll do an open approach, especially if the patient has risk factors like they're morbidly obese or they have multiple comorbidities. I mean, things go into that the surgeon can determine, but in most cases, it's going to be a laparoscopic approach. And then if the appendix has been found to have ruptured already, the patient's usually going to be pretty severely ill. They are going to be in the hospital for quite some time, usually require ICU admission for IV antibiotics until they're afebrile and their white count starts coming down. And once they become afebrile, we'll usually watch them for another day or two to make sure that they don't re-spike a fever, and then they can be sent home. They're usually in the hospital for quite some time. This can make them very, very sick. If you think about what that appendix is holding, if it's stool or bacteria or things, and it ruptures and ends up into the peritoneal cavity, which is a sterile space, it can cause the patient to become very sick and septic. So we've got to watch for that very closely. Post-operatively, again, they're always at risk for infection after surgery, but especially abdominal. Risk for decreased fluid volume, so we're going to be fluid resuscitating them. Pain management, that's true for any abdominal surgery. Restrict lifting for 4 weeks at least so that area can heal. Anytime you lift, you're engaging your core muscles. Any abdominal surgery will have you for a minimum of 4 to 6 weeks restricting your lifting. And then other usual post-op care for abdominal surgery patients. You definitely want to prevent pneumonia, and we do that by cough, turn, deep, breathe, incentive spirometer, getting them up and ambulating, prevent DVT. So while they're in bed, they're going to be wearing their TED hoses and their sequential compression devices, their SCEDs, and sometimes even taking like a low dose Lovenox shot, or maybe even a little sub-Q heparin shot. Splinting, so we want to teach them as they're preventing pneumonia and doing their cough, turn, and deep breathe. You can use a pillow and put it up against your torso and hold that as you're coughing. That can help patients provide a little bit more comfort as they're doing those different activities. And then early ambulation. These people will almost always fight you and say, no, I don't want to get up. I'm in pain. Da, 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 da. Well, they have to. And we need to explain to them the risks of not getting up, like their bowels becoming paralyzed and they won't move. Then they can develop something called a paralytic ileus, which is obviously not a good thing. That means that part of their small intestine is paralyzed because we didn't do the adequate ambulation. And that essentially causes like a fake kind of obstruction. It's not a mechanical obstruction, but since that area can't move contents like it should, things will get backed up. So it is still very similar to an obstruction. And then we'll have to do things like put an NG tube down them to decompress their stomach while they're healing. Sometimes that requires surgery in and of itself. So we don't want to go down that rabbit hole. Just tell them to get the heck up and walk. Peritonitis. So we've mentioned this with appendicitis. It results from a localized or generalized inflammatory process of the peritoneum. So something has happened either locally or systemically to cause the peritoneal cavity to become infected or inflamed. The peritoneum is definitely normally sterile. So if anything gets into there that is not supposed to be there and isn't sterile, it's going to cause problems. Causes can be bloodborne organisms, genital tract organisms, and cirrhosis with ascites can lead to peritonitis. And we'll talk about that in the liver chapter in just a few, in our next recording. Secondary causes are more common, and those are listed on the right of the slide. So those are things like appendicitis with rupture, blunt or penetrating trauma. So if we have like the spleen rupture from a trauma, from blunt trauma, or your intestines can rupture from blunt trauma, or penetrating trauma with a bullet or some kind of penetrating object like a knife or whatever that can penetrate people. If that penetrates through an organ and the release of that causes spilling of those very non-sterile contents out into the peritoneal cavity, that'll definitely cause an issue. Diverticulitis, which we talk about in the second part of this PowerPoint, that's a chronic condition that we're going to talk about. If that causes a rupture, then that can lead to peritonitis. Ischemic bowel disorders, so anything that can cause you to become septic can cause you to go into multiple organ dysfunction syndrome, which can lead to ischemic bowel. Another thing that can lead to ischemic bowel, like that we've talked about in our neuro section, is spinal cord related injuries where we're not perfusing the bowel enough. Same thing if we have an aortic injury and we have to go in and do clamp. So the clamp time, that's why that's important to know, because if we're clamped for too long, longer than 30 or 45 minutes, then we did not perfuse the bowel for long enough, and they could have ischemic bowel disorders from that. Pancreatitis. Pancreatitis can be acute or chronic, and we talk about that in the next PowerPoint. But if any kind of pancreas enzymes get out into the peritoneal cavity, that's a huge issue. Perforated intestine, we just talked about. A perforated peptic ulcer that we talked about in the upper GI section. If part of the stomach or the duodenum from a peptic ulcer ruptures and perforates through that tissue, then we're going to have spillage of GI or duodenal contents into the abdomen, and that's no good. Peritoneal dialysis, which we talk about in our renal and urinary section, but that's a type of dialysis where we use the sterile peritoneum as kind of our dialysate. Again, if that doesn't make sense, we're going to get into it in the renal section even more, and it'll make a little bit more sense. But if that catheter were to be infected, then that can cause a peritonitis, and then certainly any kind of post-op complications. So any of those things, or primary causes from like bloodborne organisms, from sepsis, genital tract organisms, or cirrhosis from ascites, all of these conditions lead to massive fluid shifts in the peritoneal area, which causes a lot of peritoneal edema. And just like we learned about with the brain, there's only so much swelling that can occur in the brain before it dies. Now, what's a little bit different is that the head has the skull, which makes it much less flexible for swelling. But any kind of compartment in your body, whether that's the brain, whether that's your arm, if we're talking about compartment syndrome, or your leg, whatever that may be, the same is true in the abdomen. So you only have so far that you can swell in your abdomen before you get into hypovolemic shock, ischemia, changes to the cells. You're going to go straight into sepsis. Taking up a bunch of space in your abdomen is going to cause your thoracic cavity to be, shrunken and compromised as well. If the lungs can't inflate because they're pushing up against a full abdomen, then we're going to get into areas of complications with pneumonia because we're not able to inflate our atelectic, what are they called? Atelectasis. It will cause atelectasis. Why am I going blank right now? Your little grape-like sacs in the lungs. I don't know why I can't think of the word. Atelectasis. Atelectica. This is going to bug me. Hang on. Y'all, I legitimately just Googled that. Your alveolar sacs, and if they collapse, they cause atelectasis. Oh my gosh, I got so tongue-tied and confused for a second. But when all of that happens and your lungs aren't functioning properly, it can lead to acute respiratory distress syndrome, or ARDS, which you're going to learn about in critical care. So that's not a concept we're going to get into detail in this class in. But that's a horrible place to be at. It's very hard to get patients back from ARDS. There's just such a dysfunction between the diffusion, like gas exchange occurring, and ventilation. It's really hard to get patients back in sync and their lungs functioning properly. They're at a high risk for death in these situations. So we have got to stay on top of conditions that can lead to peritonitis. There we go. Clinical manifestations of peritonitis. We talked about this a little bit in the upper GI section with perforation. It looks almost exactly the same because it causes peritonitis, right? So we're going to get very severe abdominal pain. And just like we talked about in class yesterday, we're going to have that rigid board-like distension. The patient's going to be very, very, very tender. Their entire abdomen is going to go tight and distended, very, very firm. Movement will cause pain. So this is something we do in trauma all the time, is we'll watch people, so if they have like a spleen injury and we're like, they're stable, we don't necessarily want to take it out right away, they might be okay and heal on their own, let's see how it goes. Well, what's a way that I know as a nurse that I need to call the doctor and be like, I'm not sure this is going well, besides the fact that they could become tachycardic and hypotensive if they become more and more tender as time goes on. That's why I'm going into that patient's room every hour or two and putting my hands on them and touching their abdomen. And if they continually are getting progressively more tender, time's up, we need to go to OR. But that's what that movement, because they're getting more and more peritonitic is what we call it. I'm not even sure if that's actually like a true medical term, but I'll usually call the doctor and I'll be like, okay, they're extremely peritonitic and they know what it means and they'll show up. Nausea, vomiting, they certainly don't want to be eating anything. Signs of shock with the tachycardia, tachypnea, low blood pressure, and they can become febrile. Although I'm not checking their temperature in these situations, I'm just trying to get them mobilized to OR. Diagnostic studies on their CBC, we're certainly going to see an elevated white blood cell count. If we were to do an X-ray or a CT on somebody who's more stable, obviously we're not going to stop and do these diagnostic studies. If they're unstable, we're just going to go to the OR. But if they have stable vital signs and we're concerned about what's going on, we can do an X-ray or CT, and we're going to see something called free air, and it will even be dictated as that in the read of that scan. It'll say there's evidence of free air in the abdomen, and that means that something hollow has perforated. So that's like the stomach, the smaller large intestine. So if you have like a peptic ulcer that's perforated, that's going to cause free air because that's a hollow organ. In liver and spleen injuries, like we would see in trauma, we're going to see free fluid because they're bleeding into those areas. The liver and spleen are both solid organs. They're not hollow and they're very vascular. So they'll just be bleeding into the abdomen, the peritoneal cavity, and we'll see something called free fluid on those. If we were to see a CT, if we were to do a CT or ultrasound, you may also see something like an abscess. So if they had another cause of peritonitis, which I haven't mentioned yet, is they would have had a previous surgery. And then as they were healing from that surgery, say they had an appendectomy and they're healing from the appendectomy, and maybe they didn't take their antibiotics as prescribed or whatever, and they developed an infectious collection of pus in their abdomen, that's an abscess. And so that could certainly, and oh God, if that ruptures, that's a problem. You're just sending pus out into the peritoneal cavity. That's a bad thing. So any of those things would clue you into peritonitis. If I were to ask a test question about this, I could say, I could think of a couple ways right off the top of my head. I could say, all right, you've got a patient that comes in with who's post-op day 10 of an appendectomy. They were sent home without complication. They're back today with tenderness, fever, tachycardia, and nausea and vomiting. You get their labs back and their CT back, and it says they've got an elevated white blood cell count of like 20, and they have, an abscess on their scan. What are they at risk for? The answer is peritonitis. Or I could say the patient comes in and we've diagnosed them with peritonitis. Select all that apply of different diagnostic studies that you would see. And I might put, like a white blood cell count of 18, free air on their CT scan, widened mediastinum on their chest x-ray. That's an aortic injury, so that's not it. Like I could just list out. So there's a couple of different ways I could ask you about something like this. That's how you need to interact with these slides as you're studying. What are the signs and symptoms that somebody has peritonitis? What are the causes? I could say somebody came in with a history of diverticulosis. They're seeing today for abnormal vital signs, increased pain, nausea, vomiting. That means that they have diverticulitis. How do we know it's progressed to peritonitis? Well, I'm going to say something from this slide. That's how questions are made. That's how you can think about these slides as you're studying with them. That's how you interact and do more than just reading them and trying to blank memorize them. That's horrible and kind of a waste of your time. That's why you're not retaining the information. So, and it's hard to learn how to study. It's hard because it just is. There's so much information. I know it's so hard to get into your head and retain it properly for a test, but I just wanted to give you some tips there on how to better interact with this material to make it stick better. So treatment for this, most certainly fluids for losses. They're going to be going into some hypovolemic fluid shifting. So fluids, whether that's crystalloid, whether that's albumin, if they have a liver issue and they're not producing the protein albumin, then we need to give that to them. And albumin's responsible for keeping volume in the vascular space. So it'll keep it from the capillaries leaking out, and third spacing, it'll protect that and keep it all in the vascular space. Or depending on the cause, they may need blood products, whether that's PRBCs or FFP, fresh frozen plasma or platelets, whatever. We need to treat the underlying cause, give them what they're losing. Certainly antibiotics for infection. We need to be giving prophylactic antibiotics to prevent this from going into a realm of sepsis and MODS. Certainly NPO, we need to allow the GI system to rest. We don't want them to have the responsibilities of absorbing and digesting and eliminating. We want them to be resting. They may progress to a point where they need an NG tube for decompression. So we're going to put that to insert an NG tube, put it to low wall suction so that it's constantly suctioning out any extra gastric juices or fluids that could be there that could cause further aggravation to the injury. Analgesics, for sure, they're going to be in pain. And then exploratory laparotomy is a procedure where they go in and they open up the belly from like the xiphoid process down to the pelvic, open them up and try to clean everything out. If they know what the issue is, then they're going to try to target that. If they don't know what the issue is, and that's where they go exploring. They're trying to figure out what happened to cause this patient to develop peritonitis. So that's peritonitis. It's a big bad guy, but it makes sense when you sit down and think about what causes it and how to treat it. Gastroenteritis is what we commonly think about when we hear like GI bug. So this is inflammation of the stomach and the upper small intestine that causes nausea, vomiting, diarrhea, fever, abdominal cramping. We've all been there, done this, had this gastroenteritis. Most common cause is viruses. A lot of the time, I know growing up, I used to get a GI bug like every year in the winter, knock on wood. It's slowed down a little bit since I've been an adult, but it's very common to happen. And there's nothing to do for it. You just want to make sure that you're managing symptoms. It is self-limiting. It's going to heal on its own, that you're drinking plenty of fluids. This is your grandma's or your mom's cure of Sprite and saltine crackers. Nice, simple things, nothing that can make you more sick. Like you're not going to eat any food that has a lot of spices on it. Everything's very plain. Ginger ale, water, Sprite, whatever you can keep down to keep yourself hydrated and settle your stomach. Now we're going to get into intestinal obstruction. So this is where I had mentioned paralytic ileus, if patients aren't ambulating after a GI surgery, but there also is certainly mechanical obstruction as well that can cause the contents of the intestines not to pass properly through the GI system. So if you can, obstruction, that's clear. Things aren't going to pass through. It's going to cause things to back up, and that can certainly be an issue. An intestinal obstruction can occur in the small intestine or the large intestine. We can categorize it as mechanical or non-mechanical. So mechanical is those actual physical obstructions of the lumen, or there's the non-mechanical, which is like the paralytic ileus that we talked about, where there's reduced or absent peristalsis. We can also call it partial or complete. So there can be a partial obstruction where some things are still getting through, but not everything. We can tend to treat that conservatively, and then over time that will open back up. If it's a complete obstruction, we certainly need to go to surgery to open that back up. And then we can categorize them as simple or strangulated. Simple refers to the obstruction as having an intact blood supply. If that area is not getting blood supply, it's called strangulated. So that area can very quickly become ischemic and infarct and become dead. And you do not want dead tissue sitting in your abdomen. That's going to lead to very bad things like ischemic bowel. So common mechanical causes are surgical adhesion. So if the patient had had a surgery before, as that area heals, then it can scar and cause surgical adhesions. Hernias can, depending on where they're protruding out into, can cause compression to an area of the intestines and cause an obstruction. Strictures from Crohn's disease, which we're going to talk about in just a few slides here about what Crohn's disease can cause, but the strictures would be like a narrowing of that lumen of the small or large intestine. Intussusception is where, and this is way more common in pediatric patients. However, I had a nursing professor when I was in nursing school who had to have emergent surgery for intestinal obstruction because she developed intussusception, which is so extremely rare in an adult. It's kind of crazy, but it's where part of your, like if this is your intestines, part of it kind of collapses in on the other. And then the peristalsis can't work like it should. And this area becomes a site of obstruction. And then colorectal cancer, the overgrowth of tissue that occurs with cancer can cause an obstruction to the intestines. And I think I have a picture here. Yeah, I want you to look down here. This is intussusception is where the intestines fold in on each other. Herniation, so if part of the intestines herniates out to a certain area, and say it's an inguinal hernia that goes into the groin. If that goes, those are usually benign, but say they do cause a problem, they could pinch out too far to where that area gets pinched and obstructed off. Adhesion, so that's that like surgical, post-surgical healing can cause scar tissue to develop like it's showing here in this picture. Oops. And then a volvulus, which we didn't actually talk about in the other slide, but that's certainly a mechanical cause where the intestines actually flip and twist on themselves. That just looks incredibly painful, but they certainly cause obstructions. Non-mechanical causes, most common is certainly the paralytic ileus, but neuromuscular or vascular disorders can cause it too. So our neuromuscular diseases that we talked about in our neuro section, like mechanical or multiple sclerosis and things like that. And then vascular disorders, anything that would cause ischemia to the area. So aortic injuries, injuries of the mesenteric or iliac arteries can cause this, etc. I mean, there's a whole plethora of things. You don't need to, I want you to think about that for your understanding, but I'm not going to ask you on the test to list out all of the causes of intestinal obstruction, so don't stress about that too much. I do want you to understand here what the patho is, though. So there's an obstruction that occurs, whether it's mechanical or non-mechanical, which causes distension in the proximal bowel. So anything before that obstruction is going to become distended because it can't pass through properly. That increased pressure there is going to cause extravasation of fluids, meaning like the fluids are going to kind of seep out of the intestines and electrolytes into the peritoneal space. So they're losing volume, they're losing electrolytes, they're going to have risk for dehydration and electrolyte imbalances. Again, the peritoneal space is sterile, so you can have issues with peritonitis, but also when peristalsis completely ceases, that becomes an issue. Your GI system has to function, period. Like, we do not do well as humans if our GI system just decides to up and quit on us. So that's going to lead to hypotension and shock. If on top of that, the blood flow is inadequate to that area, then we're going to lead to, as I've mentioned a couple times already, bowel ischemia occurs. Bad, bad, bad. If you hear bowel ischemia, just think that's bad. Necrosis of the tissue is going to cause a super mega inflammatory process to occur, which can lead to further bowel perforation, sepsis, shock, and death. So again, not good. We got to stay on top of treating these. Clinical manifestations, regardless of the cause, we're going to see abdominal pain, vomiting, distension, and constipation. So very generalized complaints, right? This is why we have to do more detailed diagnostic studies, like getting a thorough H&P, doing a CT scan. All of these things here, especially that are pictured, are going to show up on the CT scan. So that would be our cause right there. Abdominal x-ray can sometimes show it, although we usually just go straight to a CT scan. It's way more detailed in what you're going to want to use to rule out conditions anyways. Get a full lab panel on them, CBC, CMP. Often these patients are in a metabolic alkalosis, and I'm going to talk about that for a second. So when a patient has an abdominal cause for a pH abnormality, whether that's acidosis or alkalosis, it's always going to be metabolic, right? So it's abdominal, it's affecting the metabolic rate of your body, not the respiratory ability of your body. It can lead to that down the line if we develop something like ARDS, but that's down the line. When we're talking about a patient coming in with abdominal complaints, regardless of the cause, it's going to be a metabolic part, a metabolic reason that we've developed acidosis or alkalosis. If we're continuously vomiting, I want you to think about vomit being very acidotic. You're vomiting gastric acid, right? So you're losing acid. If you're losing acid, you're going to become alkalotic. You're going to become more basic. Same with diarrhea. If you have substantial diarrhea, you're stooling a base. Stool is basic or alkalotic. So you're getting rid of alkalosis, you're getting rid of base, so your body's going to be left with more acidosis. So vomiting is going to lead to metabolic alkalosis. Diarrhea is going to lead to metabolic acidosis. Vomiting, alkalosis, diarrhea, acidosis. You need to know that for the test. All right, so for the intestinal obstructions, your treatment is certainly going to depend on the cause. We went through several different causes, but some things that are going to be true for everybody is that they need to be NPO. We don't need to be putting any more down in there to get distended and obstructed. We will do an NG tube for decompression. So that's what this picture shows. This lady's got an NG tube. It's going to be hooked up to low wall suction and try to get some of that gastric fluid out. IV fluids, certainly, because they're involved in a lot of fluid shifting and third spacing here. We need to make sure their vascular volume is full. They may need parenteral nutrition. Not always. If we can get this intestinal obstruction under control in a day or two, we're not going to start parenteral nutrition on them. If we think it's going to take longer than that, or we're hitting like the 3 or 4 day mark, we may consider parenteral nutrition. Surgery would be done to resect the obstructed segment of bowel and anastomose it to the remaining healthy bowel. So if we need to, like, we would take out the part that's obstructed, remove it surgically, take the 2 pieces of bowel that are remaining and connect them back together, anastomose them together. Now, if we do that, then that needs time to heal. So we will probably be doing parenteral nutrition on those patients as that area heals so that they can over time go back to using it, but we've got to allow it to heal so that they can regain function. And then sometimes we can do an endoscopy procedure and place a stent in that area, although that is typically reserved for patients who have like colorectal cancer, and it's just a palliative measure to help them remain more comfortable. Excuse me, or a bridge to therapy. So if they're like unstable and they're not going to tolerate a full-blown surgery, we may do a bridge to therapy, bridge to OR with endoscopy stent placement. Now we're going to talk about abdominal trauma. I'm going to leave this pretty short and sweet because it goes over it in this chapter of the book very quickly, and then it's also something you're going to go over more in your critical care class. So but just to hit on some highlights, abdominal trauma can be caused by blunt mechanisms, so anything that doesn't actually protrude into the body. So those are your NVCs, ATV accidents, motorcycle collisions, falls. All those good things are blunt. Penetrating are things that actually penetrate through the skin. So that would be your stabbings, gunshot wounds, etc. This picture here shows somebody who had blunt trauma, and it looks like he was the driver because he's got the seatbelt sign, right? So this bruising here is something we call a seatbelt sign, and that's where he was wearing the seatbelt, he got into a collision, he fell into the seatbelt hard enough for it to bruise his chest and abdomen. We'll see a lot of guarding and splinting. The reason we're concerned about seatbelt sign, is because if you had that much pressure to that area to cause an external bruise, there is usually an internal bruise as well, or like actually organ damage. So we want to look at that. If they have abdominal something going on, then they're going to have a hard distended abdomen, decreased or absent bowel sounds. Again, we'll look externally and see abrasions or bruising to the abdomen. They could be throwing up blood. That would be a problem immediately after trauma, or peeing blood, hematuria. Microscopic blood is very common in the urine after an accident, but we're concerned with gross blood in the urine. That would be a huge indicator that the kidneys, the bladder, the ureter, something has been injured. And then the most common injuries in the abdomen are to the intestines. I mean, that's what's sitting right there up front. So we can have like a mesenteric bleed, mesenteric artery injury. Stranding is what it's called on the read to the intestines. That means that they're swelling and bruising to the intestines, and we need to watch that. And then liver and spleen injuries are incredibly common in high-speed trauma injuries to the abdomen. All of those things can lead to bleeding and spilling of contents into the peritoneal cavity and cause hypovolemic shock. And then we have things called the Gray-Turner and Cullen sign. Gray-Turner sign is bruising to the flank, and that's usually associated with a kidney injury. And then your Cullen sign is bruising around the umbilicus or the belly button, and that's usually an indicator of an intraperitoneal bleed. So something's going on with one of your main abdominal organs. And then that's it for acute conditions. Now we're going to talk about chronic conditions. All right, for chronic conditions, we have 3 different categories we're going to talk about. There's irritable bowel syndrome, inflammatory bowel disease, and please do not get those confused. Irritable bowel syndrome and inflammatory bowel disease are 2 completely different things. There are 2 different kinds of inflammatory bowel diseases, and there's Crohn's and ulcerative colitis, and we'll talk about both. And then there's diverticulosis and diverticulitis. We'll talk about those together. So irritable bowel syndrome is a disorder characterized by chronic abdominal pain or discomfort and alteration of bowel patterns. Sorry, I still get out of breath. Functional GI disorders, it is a functional GI disorder with no known organic cause. So basically, IBS is a diagnosis based on elimination of other disorders. So somebody comes in and they have recurrent chronic issues with abdominal pain, abdominal cramping, alterations in their bowel patterns, and they get worked up for Crohn's and ulcerative colitis and acute conditions, et cetera, and we can't figure out what's wrong with them. Then we're going to kind of turn to a kind of an umbrella diagnosis of irritable bowel syndrome. It is fairly common, and especially in women. Women can have a lot of issues with their GI system and get kind of an IBS diagnosis pretty frequently. There is no single therapy that's effective for all patients. So it becomes it largely becomes the patient taking charge of how to fix this, because again, no single therapy is going to work. So a lot of times it's just a process of trial and error. What medications do tend to help, what don't, what kind of triggers have they found cause a flare-up of their system, and how can they eliminate those triggers. Precipitating factors for a flare-up of IBS is stress, psychological factors, food intolerances, and like natural distension. So gas-producing foods, carbonated beverages. I know women that have IBS that will have a flare-up on their period with bloating. So it is a very real condition, but we just have to, it takes some time to get to that diagnosis because we have to eliminate all other possible disorders as well. In order to diagnose IBS, after we eliminate other disorders, kind of the criteria that somebody needs to meet to have an official diagnosis of IBS is 3 months of pain with 2 of the following 3 symptoms. So either the symptoms are relieved with defecation, there's a change in stool frequency at the onset, so they're either constipated or having diarrhea, or there's a change in stool appearance at onset. So they go from solids to liquids, or they change colors, etc. But they have to have 2 of those 3 things, plus 3 months of pain. And then the treatment, again, it's highly driven by the patient, and a really good primary care provider will help with this as well. Stress reduction, taking medications for constipation or diarrhea, whichever one they're more prone to having. One medicine that's been shown to help extremely well with the pain that's associated with IBS is a medication called dicyclomine or Bentyl. It's an antispasmodic medication that really seems to help with abdominal cramping that occurs with IBS. Tricyclic antidepressants have also been known to help, and then dietary modifications, again, figuring out what are the triggers, what causes these symptoms to occur more often, and eliminating those foods or drinks from your diet. Now we're going to talk about inflammatory bowel disease. And again, these are the 2 conditions, Crohn's and ulcerative colitis, that we're going to talk about. This is a chronic disorder of chronic inflammation of the GI tract characterized by periods of remission and exacerbation. So just because you have IBD, one of the IBDs, doesn't mean that you're going to constantly and continuously be having problems. Just like with MS or Parkinson's or whatever other chronic conditions, you're not constantly having an exacerbation. So you're going to have periods where you're okay, and then periods where the disease decides to flare up. Causes are unknown, although we do know that it involves some combination of environmental factors, genetic predisposition, and alterations in immune function. So we are playing around with the idea in research that this could have autoimmune components, certainly environmental factors, and then family history can affect this as well. Ulcerative colitis, remember colitis, colon is the large intestine. So that's how you can remember that this is limited to the colon. If you have ulcerative colitis, you only have symptoms in the large intestine. Now for Crohn's disease, it can affect any part of the GI tract. So try to remember it like that. Crohn's disease we'll talk about first. It occurs anywhere in the GI tract, but it commonly occurs in the distal ileum, so that's the distal part of the small intestine, and the proximal colon. So around where the appendix is what we're talking about here. Segments of normal bowel will occur between diseased portions. So we call them skip lesions. So you'll have a section of bowel that's nice and healthy and fine, then you'll have a little section that is diseased. Then you'll have a section that's fine, then you'll have a section that's diseased. And so that's what we call the skip lesions. It involves all layers of the bowel. So if you have a section of bowel, it affects all of those, the inner, medium, and outer layer of the mucosa. So what does that put the patient at risk for if they have Crohn's disease? It puts them at risk for strictures, which can cause intestinal obstructions. That's what we were talking about. So there's not a picture of that here. Yeah, so here, and then in 2 slides from here, we're talking about strictures, which narrows that lumen. And if it narrows too far and stool can't get past it or food can't get past it, depending on if we're in the small intestine or the large intestine, then we're going to have a mechanical obstruction occur. Bowel obstruction, that's what we just talked about. Abscesses can form with Crohn's disease. They're at risk for that. And we kind of have a picture here on the left side of a pocket of pus is what abscess is. It's a pocket of infection. We got to get that out of there. Fistulas, which are, and you can see here, fistula tracts, there's this black line going from the abscess to the rectum or the anal area. So that means if that's connected like that, it's basically a tunnel from, my dogs are barking so much. I'm so sorry. Hang on just a second. Sorry about that. So a fistula is basically a tunneling from one organ to another, or from one organ to the skin, or to an abscess like this picture shows. And obviously it's not supposed to be there. So fistulas occur, in this picture, it's occurring because that abscess is connected to the anal area. And so this patient is probably also pooping out pus from the abscess because they're connected. So if they're whatever components, and that can go back and forth. So stool could be getting into that abscess pocket too. So it's not good. And fistulas are very common in Crohn's disease. And then if any of that ruptures, a bowel obstruction perforates or an abscess perforates, we can lead into problems with peritonitis. Clinical manifestations of Crohn's disease are diarrhea, weight loss, abdominal pain, fever, and fatigue. So these symptoms are almost identical to ulcerative colitis. So you don't have to remember 2 different things here. Out of breath. What you do need to remember is that ulcerative colitis has bloody diarrhea. So that's a main difference here. Crohn's disease will have the generalized abdominal symptoms of diarrhea, weight loss, abdominal pain, fever, fatigue. Ulcerative colitis has all of those things, but the diarrhea is bloody. The other thing that you need to remember about the difference here is that their complications are a bit different. So we're talking about all layers of the bowel are affected, and these are the complications that can occur. The complications in ulcerative colitis are occurring in the inner layer of the intestines, the mucosal layer, rather than all layers. That's Crohn's disease. In ulcerative colitis, it's the inner layer. And that can cause things like pseudopolyp and toxic megacolon to occur. Pseudopolyps can cause intestinal obstructions. They're benign, they're not cancerous, but they can cause obstructions. So that's where the problem comes from there. And toxic megacolon is dead bowel, which is bad. Obviously, we've talked about that a lot. Inflammation usually starts at the rectum and then moves in a proximal fashion back to the cecum. So like this picture shows, it would move from the rectum all the way up and back. Again, colitis, it just affects the colon, the inner layer of the colon. Clinical manifestations are the same between the 2. Just remember bloody diarrhea for ulcerative. And then here's what it looks like. So ulcerative colitis, it's limited to the colon. You see it going from the rectum and anus upward. And then Crohn's colitis can affect the small intestine and the large intestine, and it usually does so in a skip lesions fashion. Here's what we're going to see for both conditions. And you need to know this slide. You need to know the difference between the two, but also what they share in common, which is what the slide would be. Often on their CBC, we see low hemoglobin and hematocrit and low iron. So they have iron deficiency anemia. For white blood cells, we're going to see that be elevated in conditions when we have a perforation, like we've already talked about, peritonitis, and toxic megacolon. Our electrolytes are going to be all over the place. We're going to have sodium, potassium, chloride, abnormalities because of diarrhea. And again, that leads to metabolic acidosis. We may need to give albumin back to them because it's going to be low if they're not eating good nutrition, because albumin comes from protein, or the disease process itself is going to cause protein loss from the bowels. So they may need supportive albumin, again, to keep the fluid within the vascular space. ESR is erythrocyte sedimentation rate, and CRP is C-reactive protein. Those are both elevated in conditions with inflammation. So both of these are obviously processes of inflammation, so they're going to be elevated. And then we will often get stool cultures with these to assess if there's any associated infection going on as well. The goal for both diseases, ulcerative colitis and Crohn's disease, is to decrease inflammation and maintain remission. It is a chronic disorder. There is no cure. However, we are going to do our best to decrease the amount of time that they're in exacerbation. Drugs that they may get are aminosalicylates, which suppress pro-inflammatory cytokines and mediators. So obviously we want to suppress that immune system because we want to decrease inflammation. Antimicrobials, especially if they have an infection or if they're going to be at risk for an infection. So we can either use it to prevent or treat any kind of infectious organism. Corticosteroids do the same thing as the aminosalicylates. We're going to decrease the inflammatory process. And the same with immunosuppressants. We have four drugs, immunomodulators do the same thing. 4 of these 5 drugs on this slide specifically decrease the immune system. Corticosteroids decreases inflammation, which therefore decreases the immune system. So they're all doing the same thing here. Antimicrobials are specifically against the infectious agent. So, and then immunomodulators inhibit cytokine tumor necrosis factor or prevents the migration of leukocytes from the bloodstream to the inflamed tissue. Tumor necrosis factor is so basically it's a bad guy in the immune system. So when we have some kind of inflammatory process occur, tumor necrosis factor is naturally admitted from that inflammatory process. The body interprets that as we want to send more immune system fighters, more leukocytes, more phagocytes, more T lymphocytes, more B lymphocytes. We're going to send all the bad guys to help fight this tumor necrosis factor more. That's all going to collect and blow up. It's just going to build and build and build and build and build. So the immunomodulators help inhibit that process from occurring and decreasing inflammation. Surgical therapy. So I did say that I'm going to go back on myself here. Irritable bowel disease or inflammatory bowel disease, is usually chronic. There is technically a way to cure ulcerative colitis if you take out the entire colon, which makes sense. However, you don't typically want to immediately take out somebody's colon. You want to keep them in a normal function and quality of life for as long as possible. So people will actually usually elect to live with their colon, even though you could have ulcerative colitis flare-ups. They'll just take the medication to try to eliminate it. If they're not having good outcomes with the medication, then they may elect to do a total proctocolectomy, which is removal of their rectum and all of their colon. So they will require an ileostomy after this procedure, but then they won't have ulcerative colitis anymore. Crohn's disease, you can't take out the entire intestines. That's just not possible. So they will have that for life, and you can do surgical therapy for them for any complications that occur. So going back to that previous slide, what are our complications? Things like strictures. We have our intestinal obstructions, abscesses, fistulas, peritonitis. So those would all require surgical treatment. If we continually take out pieces of bowel with each surgery that we do for them, it can lead to short bowel syndrome. I've had I've had a couple patients with short bowel syndrome where they do not have enough intestines anymore to maintain normal nutrition and hydration. So I've had patients with short bowel syndrome who were they require parenteral nutrition because they're not getting enough enterally anymore. But I've had patients who can do both. They get TPN to make sure that they're getting all of their good nutrients, but they can also eat some things. And they have an ileostomy because they don't typically, have a rectum or a colon anymore, things like that. And then we're not going to go through this again. The post-op care for both of these procedures is similar to any abdominal surgery. And this is a picture. So if we're doing a proctocolectomy, we're going to remove this dark red. The entire procto is the rectum plus colectomy, that's the colon. In a colectomy, the rectum is preserved. And oftentimes what you can see done in here, even when the colon is removed, colectomy, sometimes they can reattach the ileum to the rectum and preserve normal defecation patterns. In order to allow this to heal properly, they usually get a temporary ileostomy bag. And then when the rectum has healed some, then they can anastomose the ileum and the rectum together to preserve normal defecation. So diverticulosis. This is a good picture of it here. There are saccular dilations or outpouchings of the mucosa that develop in the colon. So it's usually limited to the large intestines, and for whatever reason, these little outpouching pockets occur. It can occur anywhere in the GI tract, but again, it's usually in the colon and actually usually in the left descending sigmoid colon. So if you think about the colon begins in the right lower quadrant at the cecum and the appendix, it goes up. The ascending colon, that goes up the right side of your abdomen. It transverses across, kind of subxiphoid there, it transverses across, and then it descends down the left side. So we're in the descending, and the most distal part of the large intestine is the sigmoid colon. So that's where it's more common to occur. And it occurs in weak points in the intestinal wall. So just like things like aneurysms occur in weakened blood vessels, these outpouchings occur in weakened intestinal areas. Risk factors are lack of dietary fiber intake, obesity, inactivity, smoking, excessive alcohol use, and immunosuppression. I mean, all of that completely makes sense. So this is kind of a picture here. This is the left side that it's talking about in the sigmoid colon right before the rectum. There's inflammation of the that's diverticulosis. In and of itself, this is just a disease of the outpouchings. Diverticulitis is when one of those outpouchings becomes inflamed. Diverticulitis. So that's the difference there. But you can see normal diverticulosis in this picture, the little outpouchings. The red ones are the diverticulitis, the inflamed and angry ones. This can result, if it's not taken care of properly with antibiotics and fluid support, these can result in perforation. That little diverticula can bust and cause perforation. It can lead to abscess formation from the infection, so a pocket of pus. It can form a fistula to another organ, or just like this picture shows, it can cause abnormal bleeding. So what are we going to do here? Clinical manifestations of diverticulosis, just having the outpouchings. There's almost never any symptoms with diverticulosis. I've never met somebody who has diverticulosis and has recurring issues. The issues come when those outpouches, those diverticula, become inflamed. Now, if they have like a little obstruction of a diverticula that then passes and it doesn't develop into diverticulitis, you can experience abdominal pain, bloating, flatulence, changes in bowel patterns. Those are usually self-limiting in just diverticulosis. Now, in diverticulitis, inflammation, we're going to have acute pain that's much more severe than you would see it up in diverticulosis. Sometimes you can feel a palpable mass from that enlarged diverticula that's occurring in the left side of their abdomen. Nausea and vomiting, and then this can certainly very quickly progress to systemic signs of infection. So that would be things like fever, tachycardia, tachypnea, hypotension. Diagnostic studies for these, a sigmoidoscopy or a colonoscopy will certainly diagnose this. That's actually what this picture is from here, is a colonoscopy. A sigmoidoscopy is simply just going into that distal portion of the colon. It doesn't go as far in. A colonoscopy will get the entire colon. But then you'll see these outpouchings here. And then a CT scan with oral contrast, that contrast will go up into that diverticula and be highlighted on the CT scan. Treatment for just diverticulosis is to avoid nuts and seeds. Those can get caught up into the diverticula easy and cause a diverticulitis flare up. So we basically say, don't eat nuts and seeds. If they have a diverticulitis occur, then they need to be on colon rest. So we want to let that heal, let our medical management do its thing. They need to be on a clear liquid diet and PO antibiotics if they're okay to go home. If they're going to be hospitalized, it's usually bad enough that we need to give them IV antibiotics, IV fluids, especially if they're dehydrated. That would be a reason for them to come into the hospital. They're going to be NPO, complete bowel rest, and we want to prevent complications. If the antibiotics and the NPO are not working for this diverticulitis, they may need surgery, or if they're having continuous rebouts of diverticulitis, then they may need to have a resection of that part of the colon and anastomosis to another part of the colon. So what can happen here is we can take out this part that's really causing problems here, and then anastomose those back together to regain function. Now, one thing they might do is do a temporary proximal colostomy while they let this anastomose and reheal together. And then they can reverse that colostomy and when that anastomosis is healed, and then they can regain normal defecation again. Colorectal cancer. This is the second leading cause of cancer-related deaths. It is the third most common cancer in men and women. And risk factors are family history, a personal history of inflammatory bowel disease. So if you have Crohn's or ulcerative colitis, it does put you at risk for colon cancer. Obesity, smoking, alcohol abuse, diabetes, and over your lifetime, a high red meat intake. Prevention is one of the 5 of these things after 50. Now, it's going to be sooner than age 50 if you have a high family history. So my family has a really high family history of colorectal cancer. I have to start getting checked. It's recommended by age 40. So it just totally depends on like what your primary care physician recommends for you and what kind of family history you have. If you don't have a family history, then starting at age 50, you can do one of these 5 things. The gold standard is a colonoscopy every 10 years. Now, for me, that's more like every 5 years because of my high family history, for example. A flexible sigmoidoscopy, so that's just that distal part of the colon, it doesn't go as far in, every 5 years. A barium enema every 5 years. I don't think that's as good or dependable, but that's where you get a barium dye enema, and then they take an x-ray and take a look at everything. A CT colonography every 5 years, or a stool specimen every 1 year. You don't do all of these things. You do one of these things and kind of follow that routine unless you have issues, and then that may change your what your doctor wants you to end up doing. But clinical manifestations, like all cancers, it's insidious in onset, meaning that it doesn't show a lot of specific signs and symptoms, and it's progressive. Non-specific findings include fatigue and weight loss. They may have an iron deficiency anemia, so low iron and low hemoglobin and hematocrit on their CBC. Rectal bleeding can usually be an earlier sign of colorectal cancer. Generalized abdominal pain, a change in bowel habits, and intestinal obstruction or perforation without like another cause for it could be cancer. Anytime older adults have issues or somebody that has a family history has rectal bleeding or fatigue and weight loss of unknown cause, or like an acute change in bowel habits, they need to get to the doctor. That could certainly be a sign of colorectal cancer. Treatment, obviously surgical treatment to take out the tumor, and then chemo and radiation depending on what the oncologist wants. That's true for any cancer. I'm not going to go into detail on that. And now we're going to talk about ostomy surgeries. This is important for you to understand. An ostomy is defined as a surgical opening on the abdomen that allows discharge of body waste. So ostomy, that's what ostomy is. You can have an ostomy in the small intestine. That's an ileostomy, based on the name. Ilia, it's in the ileum, ileostomy. Or a colostomy, it's somewhere in the colon, colostomy. So you just put those together, you'll know where it's coming from. The stoma refers to that actual outermost portion that's visible on the abdomen, that actual outpouching. The more distal the ostomy, the more functioning bowel remains, which makes sense. The further down the GI tract you get, the more the GI system functions normally, and the more likely the contents will resemble normal feces. So if you have a colostomy, especially if it's more distal in the colon, it's going to look closer to regular formed stool. If you have an ileostomy, that's in the small intestine. That means that the colon's not there to do to reabsorb fluids and to form solid stool. That's where bulking of the stool occurs, is in the colon. If we don't have the colon and the ostomy is in the ileum, then the stool that comes from that is going to be liquid. So that's a good thing. If you're not sure, or you can't find it in the chart what kind of ostomy the patient has, you can kind of look at the function, the consistency of the stool, and get a good idea of where it might be. So you can have a colostomy in the ascending colon. You can have a descending colostomy, so that's much more distal. And between these two, the descending colostomy would have much more formed stool. You can have an ileostomy, so that would be very liquidy. You can have a colostomy down from a proctectomy. So if you had to have your rectum removed for whatever reason, then your colostomy is much more, it's down to the sigmoid and it's very formed. And you can also have transverse colostomy, double-barreled, where this is usually a temporary procedure while another part of the colon is being anastomosed together. So pre-op care. Patients have a lot of misconceptions about ostomies. It's very negatively perceived in the public and even in the medical community. So we need to provide them a lot of psychological support. This is not the end of the world. They can function and have a very normal quality of life with an ostomy. We need to reiterate that to them. Educational preparation, how do you care for an ostomy? How do you change an ostomy? What are signs that something's wrong with them, etc. Then preoperatively, we're also going to select an optimal site for the stoma. So we want the stoma to be on a flat area of the abdomen. So if it's somebody who's obese, the surgeon is going to come in and mark exactly the most optimal site for that to be. Or if they're not even if they're obese, just if their abdomen has random contouring in it, they need to fix something. The best outcomes are going to occur if we put that on a flat area of the abdomen. So that's what we're looking for. And then consult with the wound ostomy care nurse. They're wonderful resources. Get them in there and let them work their magic with the patient. Post-op care, we're going to assess the stoma every 4 hours and make sure that there's an appropriate fitting pouching system on that site. Things that we want to see are rosy pink to red. That's a beefy red color. That's beautiful. It's well healing. It's getting good blood supply. That's good. If we were to come in and assess in our 4-hour rounding that their stoma was becoming dusty blue, that is bad. That is cyanotic. That means that stoma is not getting good blood supply and it's becoming ischemic. We need to call the doctor. And worse yet, if it's brown to black, that means that tissue's dead. It's necrosed. We need to call the doctor. Stoma edema, so just like any surgery, we're going to have a little bit of swelling because we had surgery on that area. There was cuts and things. So it's going to swell up a little bit, but that should resolve within the first 6 weeks. That's important to tell patients because they're usually going to be kind of disgusted by how much that stoma sticks out. They're going to think that something's wrong. You need to reiterate to them that it's okay. That's normal. The swelling will go down in 5 to 6 weeks. And as that swelling's going down, their pouching system is going to have to be shrunken to fit. So they're going to have to cut their pouching system different every time they put that on. They need to expect that. And then the colostomy will start functioning normally when peristalsis continues. So again, this is an abdominal surgery. Peristalsis will stop for a little bit because it was interrupted. We need to get those patients up and ambulating to get that peristalsis to start kicking back in. As soon as that happens, they'll start having, and they're eating again, then the ostomy will start functioning again. Now for the pouching system, it's vital to protect the skin and provide a dependable drainage system. So what the patient doesn't want to see is this ostomy fall off, especially if they're in their public life. They don't need this to fall off. So they need to know how to do it well with that. It needs to be compatible with the abdominal contours of the patient's skin. So it's got to fit on there really well. And then if it's too big around the stoma, that stool is going to sit on the skin and cause excoriation. If it's too tight around the stoma, then it's going to cut off blood supply to the stoma. So we need it to fit properly. There are different systems, different options, depending on what the patient wants to use. There's one-piece systems and two-piece systems. There's also systems that come pre-cut, or the patient can cut them to fit. A lot of times, especially if you've taken care of a patient with ostomy, they know what to cut the centimeters at. So if you're changing their bag out, they'll say, oh, make it this centimeters. And you're like, oh, okay, cool. They know what it is. To measure, I don't do anything fancy. I just put it up there. There's usually circle measurement lines on the yellow piece that you can see here in this picture. There's usually measurements, and I'll just put a little mark there, pull it away from their stoma, and cut it out. And then especially at home, these patients can rinse and reuse bags. So that'll help cut down on price of some of their bags. And that is a clean thing to do. I mean, you just clean it out with soap and water and reuse it. So here's an example. That's what I was saying about the measurements here. This is a one-piece system where you remove the whole thing, clean it out or throw it away, whatever, and replace it. And that means that the adhesive that you're putting on there to make it stick, you're removing every time. Then there's two-piece systems where you just have the piece that you cut out and put around the stoma, and then you snap. This is like a snapping material that you can snap the bag onto. So patients can leave these on for a few days, depending on the system, and just stick that on, and then they'll remove this. They can just remove their bag to empty it and clean it out and snap it back on, and then they'll change every couple of days this piece out. So it's totally about the patient's preference and what the insurance company will pay for. Now, nursing management for an ileostomy is a little bit different. Because this is a small intestine and we're not going as far down into the GI tract for full functioning to occur, we cannot give the patient enteric-coated meds. Enteric-coated meds are broken down and absorbed in the small intestine. If we're taking part of the small intestine away, it won't fully function. So they cannot take enteric-coated meds. They cannot ever take a laxative. Laxatives function in the large intestine. They do not have a large intestine, and that can harm them. So no laxatives. They are at a high risk for dehydration because your colon's job is to reabsorb fluid from stool. That's why the stool is liquid in the small intestine and then gets formed throughout the colon. So if we're not reabsorbing fluid as that goes through the colon, then they can be at risk for dehydration. So they need to know that and be aware of that when they go home. In order to avoid blockages within the small intestine, we need to educate on a low residue diet, restrict dietary fiber that can cause them to go too much, and hard to digest foods because they don't have as far in their GI system to properly digest stuff. Avoid odor-causing foods. The ileostomies can be pretty foul smelling. And that can really irritate patients. If you've been around ostomies, you know exactly what I'm talking about. You can teach them to avoid odor-causing foods like fish, eggs, asparagus, onions, garlic, beans, cabbage, and broccoli, all things that I love. You can teach them to avoid those things to try to decrease the odor of their ileostomy. And you do not ever irrigate an ileostomy. The tissue of the small intestine cannot handle the pressure of irrigation, so you do not do that. Now, for colostomies, you can irrigate, and that's just done to regulate bowel function. Some people want to do it, some people don't. It's recommended for ostomies that are in the descending or sigmoid colon. It's only if the patient's able and interested in learning. It just helps regulate their bowel movements better. And you cannot do it if the patient has a stomal hernia. So if part of the stoma has herniated out, they should not irrigate. Or if they have a prolapse, they should not irrigate. All right, I think we have like 2 more slides left. We already talked about what fistulas are. They're an abnormal tract between 2 hollow organs or a hollow organ and the skin. They heal either spontaneously or require surgery. Now, they usually require surgery, and this is very common in patients with Crohn's disease. Hemorrhoids are dilated hemorrhoidal veins, so veins around the anal sphincter. They can be internal or external, and they are a result of increased anal pressure. So they're very common in patients who strain very hard to have a bowel movement. In patients with things like pregnancy, that can cause them because they're trying to have a bowel movement around the pressure of their baby sitting on their colon. So again, pregnant women are at risk for hemorrhoids. Prolonged constipation, so that causes an increased straining, can cause hemorrhoids. Heavy lifting, prolonged standing or sitting, obesity, and then portal hypertension can also cause hemorrhoids. We're going to talk about what portal hypertension is in the next chapter. And then our treatment for this is conservative care, creams, stool softeners, so you're not straining and you just kind of let those heal on their own. Or you can have a hemorrhoidectomy where the veins are released of their pressure. And then hernias, we've talked about these a little bit, but the technical definition is a protrusion of the viscous organ through an abdominal opening or a weakened area in the wall of the cavity. So we talked about this in the upper GI system with hiatal hernias. So part of the stomach would either slide up into the esophagus, or we've got the paraesophageal hiatal hernias. This is talking about hernias that are located in the lower GI system. So we've got we classify them as reducible or irreducible. If they're reducible, that means you could push the hernia and it'll go back in. If it's irreducible, you push it and it doesn't go back in. And we also refer to that as incarcerated. Strangulation, just like when we talked about intestinal obstructions, strangulated means that the blood supply is compromised to that area. That leads to gangrene and necrosis. They're in very severe pain, nausea, vomiting, distension. Of course, if that were to perforate, that would lead to things like peritonitis and bad outcomes. If they come in with a strangulated hernia that we see on CT or whatever, they need to go to surgery emergently. Then this is the location of different hernias. We have inguinal, which occurs at a point of weakness in the abdominal wall, where it's either the spermatic cord in men or the round ligament in women emerges, and that goes down into the groin area. There's umbilical hernias, and that occurs when the rectus muscle is weak. So it's common in patients who are obese and pregnant patients, or the umbilical opening fails to close after birth. So babies can have umbilical hernias. Those are usually resolved on their own. Femoral hernias occur through the femoral ring around the femoral groin area as well. And then ventral or incisional hernias are due to weakness of the abdominal wall at the site of a previous incision. So if they had previous abdominal surgery, then they could have an incisional hernia occur. And the treatment is either conservative and it will resolve on its own, or especially if it's causing pain or dysfunction, or if it's strangulated, then they need surgical hernia repair. Where the surgeon will put that organ back in place and usually put a mesh over it to prevent it from popping out again. Whew, that was a lot of material. Again, so you have me talking here, and you also have a lot of different notes on these slides. So as you're reviewing, keep that in mind. Let me know if you have any questions about this material, and I will send you all the chapter 43 here shortly. Thank you.